attempt at a self-sustaining public long-term care program, but it looks like we may have to wait another couple of years or so to see if that's going to be even put into effect at all. And then lastly, we were hopeful to get some changes to the medical loss ratio requirements. I'm going to cover those in more detail in the latter part of the presentation. But those are some of the areas being considered for change. Another legislative update. This is talk real quick about the Budget Control Act of 2011. This was passed in August of last year. This was the law that was passed in order to prevent us going into sovereign default and increased our federal debt limit, and it created the Super Committee, which is the Congressional Joint Select Committee, and it was charged with developing a plan to cut the deficit by $1.5 trillion. And they had until November the Super Committee had until November of 2011 to reach a bipartisan agreement and avoid the sequestration, which is an across-the-board cut in federal spending, both in domestic and the military levels. At any rate, the committee did fail to reach a bipartisan agreement to reduce that deficit. So it'll be interesting, I think, shortly when President Obama has to release his 2013 budget, what, if anything, will he name that'll be cut because of the sequestration? And I think there's also some thought that there might be a last-minute deal to avoid the sequestration, and that we'll have to just wait and see over the next couple of months or so. The regulators were fairly busy towards the latter half of the year. This is a sample of some of the regulations and regulatory guidance, sub-regulatory guidance that came out last year, and so this is what we're going to talk about today. We're going to cover the amended regulations on preventive care that add some new services for women. We'll talk about the health insurance premium credit subsidies and the summary benefits and coverage, which are in addition to the SPD requirements, and thankfully for most plans and employers and insurance companies, those were delayed back in November amid concerns from interested parties. We'll talk about the medical loss ratio changes, and then the Essential Health Benefits Bulletin that was released recently by HHS. And we'll follow that up with the IRS notice on Form W-2 reporting that was released in January that gave us some additional guidance on this W-2 reporting requirement. So in addition to the question that I get fairly frequently as to whether the law is going to get repealed, the other question is it legal? In particular, is the individual mandate legal? Is it legal for the government to require us to go out and purchase some form of private insurance or face a tax penalty? And so, predictably, suits were filed in most states across the union. There were 6 federal court decisions at the district court level, and the count there was 3-3. The courts in 3 cases upheld the administration's argument that the individual mandate was constitutional, and in 3 cases the court struck it down. These cases all happened to be decided along party lines. Democratic appointed judges upheld the law, and Republican-appointed judges struck down the law. There was some party crossover on the appeals court level. We saw judges from each side contributing to the opinions, and these first 2 cases back in June and August paved the way for our current case at the Supreme Court level on health care reform. These appeals court cases, if they had gone another way, if the judiciary had uniformly either upheld or struck down the law, and there was no disparity between the states in terms of the appeals court decisions, then we would not see this moving to the Supreme Court. However, our first 2 decisions gave us that disparity. Our June 29th decision in the Sixth Circuit found that the individual mandate was in fact a valid exercise of congressional authority, and the court upheld that law. Now, on the other hand, in August 12th of 2011, the 11th Circuit found that the individual mandate exceeds Congress's power. So right there we had our split among the divisions, and the case was cleared to go to the Supreme Court. The last case down there, the Liberty case, the court essentially punted and simply said it lacked standing at this time to pursue that case. So in November of last year, the Supreme Court, you can see them down there, they granted certiorari, which is a judicial review of 3 of the cases that were before the lower court. And they're going to essentially look at 3 major issues. The first one is the constitutionality in general of the individual mandate. And the question presented is simply, did Congress have the power under Article 1, which is the Commerce Clause of the Constitution, to enact the individual mandate? Secondly, the question is, if the individual mandate is unconstitutional, is the entire law unconstitutional? And this is the issue of severability. The question presented really is, to what extent, if any, can the individual mandate be severed from the remainder of healthcare reform? And our firm, Proskauer, actually recently put together an amicus brief for the Supreme Court on that issue, essentially arguing that if the individual mandate were to fall, or to be declared unconstitutional, then the court would have no choice, essentially, but to also repeal the employer mandate. And those 2 laws go hand in hand. And although it might seem simple and straightforward that if the individual mandate were to fall, that the employer mandate would also, it's not that simple when you're the Supreme Court. And essentially the way the Supreme Court looks at it is they take the individual mandate and the employer mandate and they look at them separately, and they say, well, can the employer mandate exist without the individual mandate? So they look at the way the law is written, and they can see that they can still penalize employers for not offering insurance. Employees can still get premium credits and go to the exchange, even if there's no individual mandate. So it's not as simple to say just because it appears that the individual and employer mandates are linked, that one would necessarily fall if the other fell. And so that was the subject of our amicus brief, and we're hoping the court sees in our favor, which is our employer client's position. Lastly, the other question that will be discussed by the court is whether this question is even ripe at this point, meaning is the suit brought to challenge the individual mandate barred by the Anti-Injunction Act. And the Anti-Injunction Act is a federal law, and it basically prohibits folks from challenging federal laws before they are really in effect or have affected that individual or have damaged someone. Right now, we have a case before the Supreme Court that is challenging the constitutionality of the individual mandate before anyone has even been subject to this law. And so the court's going to have to ask, is it even ripe to bring this challenge at this time? So there are essentially 4 possibilities that the court can decide here. They can decide that the individual mandate is constitutional, in which case the entire healthcare reform law will pretty much roll forward as it has been continuing to progress. The court could decide that the entire law is unconstitutional and do a full repeal back to the pre-healthcare reform days. Thirdly, the court could find that simply just the individual mandate is unconstitutional, and then we'll have to wait and see what, if any, other provisions are also affected by that. And as I said, whether the employer mandate also falls with the individual mandate, if the third bullet is what happens. Or the court could simply say that these challenges are not right for Supreme Court review, which will have meant they got us all worked up for nothing, at least at this time. Moving on now from the from the judicial update, talk a little bit on the regulatory side, and we'll start off with the health insurance premium tax credit. And some proposed regulations were released for this tax credit back late in the year in 2011, and it basically provides either a premium credit or a cost-sharing subsidy to individuals that are qualified to receive these subsidies and purchase coverage under the exchange. The proposed regulations clarify who is eligible for the assistance, details how it's calculated, and it also limits the circumstances where an employer is subject to the penalty under the employer pay-or-play mandate because its employees received assistance. The assistance, the federal premium subsidies, and cost-sharing subsidies and credits are available only if insurance is purchased through a public exchange. It is not available, the federal money is not available for insurance purchased through a private exchange. And the exchanges, those of you that might be familiar with the Massachusetts system know that we have our connectors here, and the exchanges and connectors are basically these quasi-governmental institutions that bridge the gap between individuals and small groups with the insurance companies. At least that's their intended function. So in order to be eligible for a credit, individuals must be lawfully present in the U.S. and they cannot be entitled or eligible for Medicaid or incarcerated. The income levels must be outside of Medicaid eligibility. So in 2014, when the individual mandate comes into effect, if it indeed comes into effect, the Medicaid levels are expanded from 100% the federal poverty level to 133% the federal poverty level, and essentially so the credits will cover folks that are about between 138% of the federal poverty level to 400% of the federal poverty level. And for a family of four, the federal poverty level gets up there. I believe it's around $86,000 or so annual income for a family of four. So if your employees are within those federal poverty guidelines and they're not eligible for minimum essential coverage, then they can potentially get a premium subsidy, which could subject the employer to a penalty. So on the employee side, his income has to be within the certain levels, and then correspondingly, he has to be ineligible for minimum essential coverage. And minimum essential coverage is basically coverage under any government-sponsored plan like Medicare, Medicaid, CHIP, or VA coverage, and coverage under an employer-sponsored plan, eligible employer-sponsored plan. So what is an eligible employer-sponsored plan? And you're going to hear about this later as well when we talk about the employer pay-or-play mandate, but an employer will not be subject to a penalty, or an individual won't be eligible for a premium subsidy or a cost-sharing reduction if his employer's plan offers quality, affordable health insurance or health coverage. How do we know if a plan is quality? We know the plan is quality, it provides quality coverage if the plan's share of the total allowed cost of benefits provided under the plan is at least 60% of those costs. And so in English, or at least what it attempts to be English, is the 60% is the actuarial value of the plan. So the plan has to have at least a 60% actuarial value. And so actuarial value is a term that consumers are going to have to become familiar with under healthcare reform, and it provides basically a snapshot or a shortcut for an individual to assess the level of coverage he might receive under a plan. And so, as you know, different people will have different experiences under their health plans. Folks that are very high utilizers are probably going to receive the greatest amount of benefits under the plan and have the lowest cost sharing on average because perhaps they've met their deductible, they have satisfied their maximum out-of-pocket level, whereas folks that are very low utilizers will have the most cost sharing under the plan because they haven't met the deductible yet, for example. So they might be responsible for 100% of their charges. So the actuarial value takes an overall picture of all the people in the plan, the high utilizers and the low utilizers, and says on average the plan is expected to cover at least 60% of those costs. And so that's what the actuarial value means. So in addition to offering quality coverage, the plan must be affordable. And the plan is affordable if the premiums for single coverage do not exceed 9.5% of household income. We expect that employers, instead of having to understand their employees' household income, basically go out and play detective and figure out what household income is, that we expect the regulations when they're released in the next couple of years to include a safe harbor that will let employers use W-2 wages instead of household income, which, while they might be a little lower than household income, at least it's a number that the employer knows and has access to. So moving away from the individual mandate, I thought it was a good idea to add a couple of just examples and common questions and misconceptions on the age 26 rule. As you know, under health care reform, approved health plans and health insurance companies that cover dependents must cover dependents until age 26 without regard to financial support, marital status, residency, really any dependency factors. And some of this has caused a little bit of confusion among employees that think that they might be able to cover anyone in their household under age 26. So it's important to address some of those misconceptions. There is one exception for grandfathered plans. A grandfathered plan may, but is not required to, exclude children who are under age 26, but who are eligible for another employer's insurance other than the plan of either parent. And this exception, if the plan is going to avail itself of this exception, must be documented in the summary plan description. It does not happen automatically by operation of law. So a lot of, just a smattering or example of some questions that we've gotten. Does a plan have to cover children? No, a plan is not required to offer dependent coverage. Of course, most plans nowadays do cover children, but it's not strictly required. Another question we get all the time is, can a plan exclude a child who is married? That is one of the dependency factors, and it cannot be a factor if the child is under 26. In other words, even if the child is married, he can still be covered under his parents' plan as long as he's under age 26. Another question that comes up all the time is, does a plan that covers children have to cover the children's children? In other words, the grandchildren of the employee. And the answer is no. Grandchildren are not on the list of children that are required to be covered under health care reform. And so the next question that we usually get is, well, if we do allow grandchildren into the plan, can we require that the employee be responsible for the grandchild? So in other words, can we add some dependency factors to a grandchild? Can we make it so that he has to live with the employee, or the employee has to be financially responsible? And the answer to that question is yes, because he's not, because the grandchild is not among the children described in the tax code for coverage under health care reform, which includes natural, adopted, step, and foster children. We can add some additional dependency factors for that grandchild. Does a plan that covers children have to cover stepchildren? It's a good question, and there's not real good guidance on this. But the bottom line is that the health care reform law does not require coverage of children. You could potentially exclude stepchildren while covering natural children and adopted children and foster children. We do think it's a best practice that if you are covering children, that you do cover stepchildren, just from an employee relations issue or standpoint. And then, of course, the next question is, well, if we allow stepchildren to be covered under our plan, can we require that the employee be financially responsible for that stepchild, or maybe require that the stepchild live with the employee? And the answer to that is no. If you do let stepchildren on the plan, you cannot apply any dependency factors to them that you would not apply to a natural or adopted or a foster child, because stepchildren are included in the definition of child for these coverage purposes. Of course, a plan can require that the employee be in a current relationship with the stepchild's mother or father. Basically the plan can verify that the child is in fact a stepchild of the employee. Moving on now to some of the other mandates. The preventive care mandate, we kind of got these regulations in two parts. The initial guidance for preventive care came out in middle of 2011. The regulations came out, I believe, actually, I'm sorry, I think it was beginning, middle of 2010, actually. At any rate, the first run of preventive care regulations were effective for plan years beginning on or after September 23rd, 2010, which is basically 1/1/2011 for calendar year plans. And this mandate required that preventive care that is ranked A or B from the U.S. Preventive Services Task Force be covered with no cost sharing. And this applies only to non-grandfathered plans. And I don't know if you folks out there listening are familiar with the U.S. Preventive Services Task Force. They are essentially going to be setting the standard for healthcare reform and healthcare coverage going forward. This was the organization back in 2009 that issued a recommendation saying that women of a certain age it was no longer recommended that they receive mammograms. And the U.S. Preventive Services Task Force ended up having to take back that recommendation amid some criticism and some concern. And so some of you out there may remember that recommendation, and that's who these folks are that are setting the rules for the preventive care coverage, and as well as other coverage going forward under healthcare reform. Pardon me. Last year, in August of 2011, we saw an amendment to the preventive care regulations, and this amendment gave us some coverage of additional preventive care services for women. And this includes birth control, including IUDs, the morning after pill, implantable forms of contraceptive. It also includes sterilization in some cases, as well as some of the less controversial elements such as cervical cancer screenings, women physicals, counseling on domestic violence. There have been a lot of questions lately as to whether these preventive care services cover abortions and abortifacients. And at this time, it does not cover abortions and abortifacients, but some of these contraceptive devices, there are certain groups that feel that some of these pills are really not so much contraceptive, but they're more of an abortifacient, essentially. And so there's been a bit of a dust-up lately in the benefits industry and in the news regarding this mandate, and maybe we'll see some additional clarification in the future. I actually received a question this morning from a client that had some employees that had heard in church that preventive care services are covering abortions and those type of drugs and services. And it's not the case right now, and we'll certainly keep you posted on those developments. The preventive care amendment does include a provision that permits religious institutions to opt out of offering birth control coverage. The opt-out, it's not exactly clear how long it lasts for, and the depth, the extent to which it covers religious institutions. We're hoping for a little more clarity on that in future months. Just make sure I'm still sharing my presentation here yet, but it looks like we're still moving along. Oh no, I just reset it. Sorry. Okay, we're back. One of the mandates under healthcare reform that caused a lot of concern for employers back in 2010 when healthcare reform was first released was the application of the self-funded non-discrimination testing rules to fully insured plans. And thankfully, most of our employers, at least, were thankful that this requirement was delayed. Basically, when the Republicans took control of the House in November of 2010, they were successful in making their constituents' voices heard, and have this mandate delayed. Basically, it would apply the self-funded non-discrimination rules to fully insured plans. And those of you out there that are self-funded know that these rules can be fairly draconian. It essentially prohibits plans from discriminating in favor of highly compensated employees with respect to eligibility or benefits available under the plan. And this would affect things like executive medical plans, carve-out plans that maybe offer better benefits to executives, management, and the reason that these rules did not apply to insured plans, at least initially, was that the insurance carriers have their own rules regarding underwriting and premium development and rating and things like that, and there's not as much of a possibility for real abuse that could exist under a self-funded plan. And so the insured plans were given a break from these rules. Healthcare reform that applies those rules to the insured plans, and it really is going to potentially have a big effect on certain industries, like folks in the hospitality industry, the restaurant industry, employee leasing companies, and the penalty is very severe. It's a penalty of $100 per day with respect to each individual to whom the failure relates, not taxation of the benefit payment, which is the rule for self-funded plans. So, for example, if and when these rules come into effect, if you have 100 employees and you cover 10 of your managers under an executive carve-out plan, then you can potentially face a penalty of $100 a day for each of those 90 employees that are not eligible for the executive medical plan. And like I said, these rules have been indefinitely delayed until further regulatory guidance is available. We don't have any real indication as to when these rules might be released. At this point, I'm hopefully optimistic that they will not become effective before 2014. And I think there's also a reasonable chance that these rules will never come into effect and will be repealed out of healthcare reform, potentially. And we'll certainly keep you updated on that. Other rules under healthcare reform include rescission. This is part of the patient protections that were instituted by healthcare reform. Basically prohibits employers from retroactively canceling coverage except in cases of fraud or intentional misrepresentation of a material fact as prohibited by the terms of the plan. So, for example, if an employee goes from full-time to part-time and the plan does not cover part-timers and the employee mistakenly just kept on paying his premiums and the plan kept him covered, as long as there's no fraud or misrepresentation on his part, the plan can't go back and rescind and retroactively terminate his coverage. And then there's some exceptions and some nuances. Basically, cancellation of coverage due to failure to timely pay premiums is not a rescission. Similarly, retroactive cancellation of coverage to the date employment terminated is not a rescission if the employee is not paid for coverage. So, for example, if the way it works at your organization is you send a feed to the carrier once a month, and if an employee terminates on the 10th or the 11th of the month, you notify the carrier on the 31st, and then you terminate his coverage as of the 10th. That's not considered a retroactive cancellation as long as the employee has not been paying for COBRA coverage. Of course, his COBRA rights still apply in that situation. Another example would be if a a husband and wife get a divorce and the former spouse was adequately informed through the initial COBRA notice that she has to notify the plan of a divorce, or at least one of them has to notify the plan of a divorce. If that doesn't happen and neither the employee nor the spouse notify the plan of the divorce, then rescinding coverage or retroactively terminating coverage back to the date of the divorce is not considered rescission under these rules as long as the ex-spouse has not been paying the COBRA premium. So, in other words, retroactive terminations that are done in the ordinary course of business are generally not prohibited by these rules. Here's another element of healthcare reform that was mercifully delayed. Those of you that were keeping tabs on this back in August were aware that Health and Human Services released some guidance on the summary of benefits and coverage, as well as the 60-day notice requirement. This was a method for employees to become better informed about their plans. Apparently, the regulators felt that the benefit summaries and the SPDs and the certificates and the open enrollment materials and the highlighters and the bulletins were not enough to communicate benefits, and we needed an additional uniform explanation of benefits, and that's the summary of benefits and coverage. It was initially envisioned that all of the relevant information would be contained on 4 pages, and when the regulators came out with the guidance, they told us that that Congress must have meant 4 double-spaced pages because they couldn't possibly fit all of the information on 4 regular pages. So overnight, this became 8 pages of a benefit summary. It has to be culturally and linguistically appropriate. And HHS did release a model form. Unfortunately, it caused a lot of confusion for our clients, especially our self-funded clients, since it was really geared towards insurance companies. So a number of interested parties wrote in, and HHS heard that and delayed the effective date of these rules until they can go back and reconsider some of the concerns raised by employer groups. And these next couple of slides just show what would be included on the SBC that is provided to participants. Information on the cost sharing and the exceptions and the other limitations, the renewability and continuation of the coverage provisions, statements as to whether the plan provides minimum essential coverage starting in 2014, and a bunch of other information that is typically contained in the highlighters, but there's some more information that will be included in these SBCs. One of the elements that caused a lot of concern for employers was the idea of a 60-day notice requirement, and that is part of this SBC, the Summary of Benefits and Coverage requirement, and that was also delayed. And before we had guidance on this 60-day notice requirement, we were concerned that a plan would have to communicate to participants any changes 60 days before the date that the change would be effective. And so that would obviously have an effect on our renewals, and one of the effects it would be that we might not get the most recent 2 months of claims history if we have to have the renewals done 60 days in advance of the effective date. And thankfully, the regulators gave us an out there, so to speak, that the 60-day notice requirement is not going to apply to changes done in conjunction with the renewal. So you don't have that 60-day notice requirement if you're making changes in connection with your plan's renewal. And of course, this is all delayed. It's not effective now, but we expect that's how the rule is going to work once the additional guidance is released. And so that, I think, is a bit of a relief for employers. They'll have some additional time to negotiate those changes with the carriers. Moving on now to something that you're probably all familiar with if you're working with folks like Todd and Brooke and John and Enabling Partners. And I'm sure they're getting their clients up to speed on this W-2 reporting. This is a new requirement in our healthcare reform, and it basically requires employers to tell employees the value of the insurance coverage they're getting each year. And the way that the government is going to track this is by Forms W-2. So essentially, the employer or its payroll company or whomever it's engaged to assist with this has to include this information purely for informational purposes on employees' W-2s that are issued in January of 2013, which cover 2012. And it's very important that when communicating with employees that you let them know that this is purely informational. And the information included on the Form W-2 does not mean that the benefits are taxable. So there was some additional guidance released in January of 2012, clarified the existence of the small employer exception, and if your company, and this is one of the few rules under healthcare reform that do not apply on a control group basis, if your company, based on your EIN, issues less than 250 W-2s in the prior year, they will be exempt from this requirement until further guidance is issued. You can comply with it voluntarily, but you will not be penalized for failure to comply with this requirement if you have issued less than 250 W-2s in the prior year. So what does this reporting consist of? You must report the aggregate cost of health coverage, and that is basically all plans, all medical plans, except for long-term care, accident and disability coverage like your life, LTD, STD, AD&D, workers' comp, similar coverage, as well as standalone dental and vision plans, coverage for a specified disease or illness like your cancer policies, your critical illness policies, or hospital indemnity or other fixed indemnity insurance. These types of plans are all exempt from the reporting. Now, there were some clarifications under IRS Notice 2012-9. To the extent that your EAP wellness program or on-site medical clinic is a group health plan, then it is potentially reportable under these rules. The Notice 2012-9 clarified this and said, if the employer provides COBRA for these types of benefits for EAPs, wellness programs, or on-site medical clinics, and does not charge a premium for that coverage, then they do not have to report the value of the EAP wellness program or on-site medical clinic. And whether these types of benefits are subject to COBRA is a very fact-intensive review, and it is not something that an employer should undertake lightly, and it should probably engage counsel to review the terms of those plans, especially if they have very robust wellness plans that might rise to the level of their own group health plan and may or may not be integrated with the employer's major medical plan. So a lot of moving parts to these requirements, but essentially EAPs, wellness programs, and on-site medical clinics are excludable as long as the employer does not charge a premium for COBRA coverage to employees. As I mentioned, dental and vision coverage is excluded to the extent it qualifies as a HIPAA-accepted benefit. I'll tell you what that means in detail in the next slide. And also, specified disease or illness and hospital indemnity or other fixed indemnity insurance is excludable as long as the cost of coverage is paid on an after-tax basis and the coverage is offered as an independent, non-coordinated benefit. So if you're offering cancer policies or indemnity policies to your employees and they are paying pre-tax, then the value of those policies is generally includable in income. I'm sorry, not includable in income, reported on the W-2, not includable in income. So to clarify when dental and vision coverage is accepted under HIPAA, there are two pieces, and one of them applies basically to fully insured plans, and one of them applies to self-funded plans. Very simply, if a plan is fully insured and the dental or vision coverage is offered under a separate policy, contract, or certificate of insurance, then it is a HIPAA-accepted benefit. So all it takes to include dental and vision coverage is if it's under a different contract than the medical plan. When you are self-funded, it's a little different because there are no policies, certificates, or contracts of insurance, so we look to see if the dental or vision coverage is integrated into the plan. So dental vision coverage, when it's self-funded, is not reportable on the W-2 if participants have to separately elect that coverage and pay an additional premium if they take that coverage. So in other words, if it costs employees $100 a month and they get medical, dental, and vision, no matter what, and it's a self-funded plan, they can't opt out of dental and vision if they want medical. It's all bundled together. Then the value of the dental and vision coverage would be included in the W-2 reporting because it would not qualify as a HIPAA-accepted benefit. Other types of costs that are not included are contributions to the Archer MSA, because that is reported separately in Box 12 Code R. Another question that comes up all the time, it's apparently due to some misinformation out there by the practitioners, the amounts contributed to a health saving account they're not reported for purposes of this W-2 reporting under healthcare reform. HSA contributions have been reported separately for years in Box 12 Code W. This requirement predates healthcare reform, so you do need to continue to report those HSA contributions in Box 12 Code W. Employee FSA contributions are not included, although employer FSA contributions are included in certain circumstances. If your Section 125 plan or your flexible spending plan involves employer FSA contributions, you should discuss that with Todd or John or Brooke, and they can get in touch with me, and we can walk you through that if necessary, if it's necessary to capture the employer FSA contributions under those circumstances. Cost of coverage under a health reimbursement arrangement does not have to be included. It may be included if the employer would like, but it is not required. Cost of coverage under a self-funded plan that is not subject to any federal continuation coverage requirements, like a self-funded church plan, is also exempt from these requirements, as well as coverage provided by a state or federal government. Similarly, coverage provided to independent contractors or retirees is not included if there's no W-2 issued. If your retirees are on the plan and they get a W-2 for some reason, maybe they have imputed income because of retiree life insurance, in that case the W-2 would be issued for a retiree. Obviously, independent contractors who receive 1099s, they do not receive a W-2 and thus would not receive any reporting, even if they are covered under the plan. You generally report the aggregate cost of health insurance coverage. That includes the employer's and the employee's contributions. It's the full rate. It's basically the COBRA rate minus the 2% administration charge. With respect to terminated employees, you can use a reasonable method for including the value. If you would like to include their COBRA coverage, you can. If you want to just include the value of the coverage during the time in which they were an active employee, you can do that as well. There is a little-known provision in the W-2 rules that permits employees to request a copy of their W-2 before the end of the plan year, and the employer should provide that. Now, the employer is not required to provide it. There's no penalty if the employer does not provide the W-2 early and simply decides to wait until it normally provides them. But if you want to accommodate an employee's request and give them the W-2 early, you do not have to include the cost of the health insurance in that W-2 to the extent it's provided early. The method for calculating the reportable cost, you can use the COBRA applicable premium method. You don't have to use the same method for each plan, but you must use the same method for each employee with respect to that plan. We generally think the COBRA applicable premium method is the right way to go. Of course, if you're self-funded, you just want to make sure that you're accurately developing your COBRA rate. For example, if you do not have aggregate stop-loss hits, then you may not want to use the aggregate stop-loss factor to calculate your expected claims. That might result in a COBRA rate that is too high. And to the extent that an employee changes coverage during the year, the cost on the W-2 should reflect the coverage he had during each part of the year. So if an employee moves from an HMO to a PPO, then his W-2 would reflect coverage under the HMO and the PPO. If an employee moves from a single to family, then part of the year his W-2 would include the coverage for single, and then the other part of the year it would include it for family coverage. Or in other words, the W-2 provided at the end of the year would reflect the coverage he had that was single coverage for part of the year and family coverage for the other part of the year. Some sub-regulatory guidance that was released, and this is part of the market reforms, and this goes along in the same vein as the medical loss ratio requirements. Health and Human Services, we were expecting them to release some real regulatory guidance on the essential health benefit definition and the essential health benefit package. Instead, they released a bulletin, which is essentially sub-regulatory guidance, but it does give us a real good idea of Health and Human Services' approach to defining the scope of benefits that are going to be offered by plans in the exchanges, as well as outside the exchange if they're small group plans in 2014. And these requirements do not apply to self-funded plans or to large group plans, but there are additional market reforms that may restrict the group health plans cost sharing starting in 2014. Also, plans that are not subject to the essential health benefits package still might be interested in what constitutes the package because their plans are still affected by the prohibitions on lifetime and annual limits on the essential health benefits package. And perhaps surprisingly, the government has said that the essential health benefit package will be defined on a state-by-state basis. And each state will select a benchmark plan that defines essential health benefits for that state. And basically, some folks out there that were clamoring for a national solution were not very happy with essential health benefits being determined on a state-by-state basis. However, that is the way that a lot of our federal programs work. Like the packages that are offered under Medicaid and CHIP are determined on a state-by-state basis, and that appears to work pretty well for those programs. Okay, sorry, just got a note here. I just want to make sure that we're still moving along. I'm going to step it up a little bit because I know we have probably some questions at the end. I'm going to move on to talk about the medical loss ratio very briefly. This is basically a mandate on insurance companies that they spend a certain minimum amount of your premium dollars on claims. And so this requirement is that the insurers spend at least 85 cents on the dollar for large groups or 80 cents on the dollar for small groups. And if the insurance companies do not meet that minimum loss ratio based on their overall book of business by state and by group size, then they'll need to provide a rebate to participants. Part of the guidance that was released last year discussed rebates that are provided to ERISA-covered plans. So for the folks out there that are listening, most of you or all of you probably have plans that are subject to ERISA. So when a plan receives a rebate, which in our opinion is pretty unlikely, I don't know if too many of you out there will ever receive rebates under your insured plans, but if and when you receive a rebate, then it must be apportioned based on the amounts contributed by the employer and the employees. So to the extent that that amounts are attributable to the employer contribution, the employer can simply keep that amount, put it back into general assets, use it however they wish. However, to the extent that a portion of that rebate is attributable to participant contributions, then they are subject to the plan asset rules, which require that they be handled by a fiduciary, and that they are used to benefit participants, meaning that they can either reduce premiums or enhance benefits. And most importantly, out of all this medical loss ratio stuff, is that if you get a rebate, you must apply it to the extent it constitutes plan assets within 3 months of receipt. Otherwise, ERISA's trust requirements are going to apply, and I know most of you out there probably do not use trusts to administer or to operate your plans. If you do have a trust and you get a rebate, you should discuss it with Benefits Counsel, and we can advise you as to how that rebate should be distributed. Some upcoming mandates in the next few years. Quality of care reporting, I'm going to skip over this because we just don't have any guidance on this yet. The comparative effectiveness research fee, this is effective for plan years ending after September 30th, 2012. So in other words, it's effective for plan years beginning on or after November 1st, 2011. So it's already in effect for certain plans. We have no regulatory guidance yet. We have no idea if, when, or how, or where to send these $2 per member fees. But we do expect some regulatory guidance on that in the near future. Our best advice at this point is just know that fee is out there and potentially budget for it. In 2013, we're going to see health FSAs capped at $2,500 per year for employee elections. It does not apply to employer contributions. It only applies to employee contributions. And there are some potential issues for non-calendar year FSAs. The contribution limit applies on a calendar year basis. So, for example, if you have an FSA that runs April 1 to March 31st, and it has a $6,000 annual limit, then that works out to a $500 per month contribution. And that means that for the months of January through March of 2013, an employee will have contributed $1,500. So therefore, his remaining limit in 2013, he can only contribute $1,000 or $111 a month for the remaining 9 months. Front-loading, meaning taking contributions up front at the beginning of the year, is not expressly sanctioned by the IRS. It could also be burdensome to employees, particularly if the plan starts later in the calendar year. And so we just recommend that you review your plans with counsel, with agent partners, and communicate changes to participants early to ensure a smooth transition. I'm going to skip over these last couple of mandates here, and just so I can concentrate on the employer mandate for a minute. The employer player pay mandate basically requires employers with 50 or more full-time equivalents to offer insurance to their employees or potentially pay a fee. And there are two regimes here. One is for employers that opt out entirely, and the other is for employers that, while they don't opt out, their coverage fails to meet certain minimum standards. If you are an employer that opts out and in at least one employee, it all takes is one employee to go to the exchange and get a federal premium subsidy, then as an employer, you would be subject to a penalty of $2,000 per year for all full-time employees, even if just one goes out and gets a federal premium subsidy. That is probably not any of the folks listening to this webinar today, but you should be aware of the penalties for providing unaffordable coverage. And this would be in a plan that had a premium that exceeded 9.5% of household income, or the plan did not provide the minimum 60% actuarial value. So if the coverage provided is either not affordable or it doesn't provide minimum quality, then potentially employees can go out if their income is between 133% and 400% of the federal poverty level, go out and get a subsidy, and that would subject the employer to a penalty of $3,000 per year per full-time employee who actually goes out and gets coverage under an exchange with a federal premium subsidy. And I'll note as a closing piece here that this rule does not require coverage of part-time employees. We're only talking about full-time employees, those working, I think for this purpose, it's 30 or more hours a week. Yes, that's right, 30 more hours a week. Automatic enrollment, not yet effective. And now I want to end my prepared part of the presentation so that we have time for some questions. And I'm happy to stay on for a few extra minutes if folks would like to ask questions through the chat box. I'm looking now at my chat box. I don't see any that have come in. Todd, your line is unmuted. I don't know if any questions came in to you, or if I should unmute folks and just let them ask questions.
Yeah, why don't we do this again? There's Stacy. By the way, thank you very much. Tremendously informative. A lot of material to those on the phone today. I just want to let you know that you can certainly go to our website and download the presentation, any follow-up dialogue, and so forth. We welcome that. For the question and answer, there's two ways to do it. There's a chat box, and Stacy, if you'd unmute the lines, we can also allow people just to
muted.
Okay. Well, in conclusion, I just want to thank everyone for participating today. A special thanks to Brooke Millian, our firm, for all her work in putting this all together. We will continue to keep you abreast of all of the developments of healthcare reform through our client alerts. We also welcome those who do not currently receive our client alerts to go to our website, and you can sign up there or certainly contact any of us at the firm. Again, we're thrilled to have you, and we will continue to provide you with timely and relevant information going forward. More specifically, our next class will be on February the 16th. Joe Bartulis, who is a lawyer here in Worcester, will be our presenter, and Joe will be talking about formal social media policies. So again, I thank everyone, and we welcome you to our website to download the information, and certainly any follow-up questions and dialogue would certainly be welcome as well. Stacy, once again, thank you for your time, for your information, and to Proskauer for your partnership.